Hello, everyone, and welcome to the Clinics Review Articles podcast series. I'm Carrie Holland, the Managing Editor for Infectious Disease Clinics of North America here at Elsevier. Infectious Disease Clinics is a quarterly publication consisting of review articles focused on a central topic related to infectious disease clinicians. Today, we will be discussing the December 2024 issue dedicated to advances in the prevention and management of device-associated infections, guest edited by Dr. Vivian Chu. She is a professor in the Department of Medicine and Division of Infectious Diseases at Duke University School of Medicine and Duke University Health System. Also joining us today is consulting editor, Dr. Helen Boucher, Dean and Professor of Medicine at Tufts University School of Medicine and Chief Academic Officer, Tufts Medicine.
Well, welcome to this podcast of Infectious Disease Clinics of North America, focused on infections related to devices. This is a very relevant and pertinent topic, one with which we deal often clinically. I am so delighted to have Dr. Vivian Chu with us today. She's an international expert on the topic of managing device-related infections and a professor of medicine at Duke. Welcome, Professor Chu.
Thank you, Dr. Boucher.
It's so nice to have you with us. And we'll talk about a couple of different areas related to device infections. And I think it's fair to say that in the United States in 2025, devices are put in great numbers. In fact, in many institutions, surgeries for joint replacement and cardiac devices are among the most common. So this is a really important topic for all of us, whether you're an infectious disease physician or not. Why don't we start in the cardiovascular space and talk about cardiovascular implantable device infections? In 2025, we're seeing all kinds of cardiac devices, pacemakers, valves, all kinds of things going into our patients in great number. And one of the most dreaded complications that we in infectious disease see is Staph aureus bloodstream infection. It's one we see everywhere, but especially worrisome in our patients who have cardiac devices in place. So let's just start at the beginning. In persons with Staph aureus bacteremia, what is the likelihood that their cardiac device will become infected?
Yes, thank you, Dr. Boucher. I'll start out by saying that when I'm on service and I see a person with Staph aureus bacteremia and a cardiac device, the answer is that the device is infected. And thankfully at my institution, the EP cardiologists are on board with that and we can manage the patient pretty efficiently. But what's the data behind that? So observational studies suggest a strong association between Staph aureus bacteremia and cardiac device infection. In one of the most quoted studies by Annalisa Chamis, when Staph aureus bacteremia occurred within a year after cardiac device implantation, 75% of persons had confirmed infection. And among those who had the device placed greater than a year out, 71% of patients had either confirmed or possible infection. So basically, the vast majority are infected. Among the minority of patients in whom we question whether or not the device is infected, it's really hard to know for sure. So there was one study that was done at Vanderbilt where they looked at over 300 patients with Staph aureus bacteremia and a cardiac device. And among the 178 who did not have any clinical or TEE evidence of infection of the device, 10% of them just had them removed anyways, which is a lot of what we do, knowing the likelihood that it's infected. But among those who didn't, the rate of relapse was fairly high at 20%. And in this study, relapse was strongly associated with duration of bacteremia greater than a day. And so when we think back at the patients that we take care of, that's just about all the patients that we see. They have durations of bacteremia that are well over a day. There is probably a small proportion of patients who get some sort of secondary Staph aureus bacteremia, not related to the device, who don't actually have a device infection yet. But at this time, it's just really hard to know who those patients are.
Yeah, great. So two things I want to highlight. One is you talked about the duration of bacteremia. And I think for this audience and every audience, one of the most important messages we can leave people with is the importance of obtaining serial blood cultures, because I think all of us are still called to see folks for whom there was an initial positive and there were not follow-ups done, right? So the presence of bloodstream infection for more than 48 hours is still a very important marker of complications and outcome. Started at Duke, I'll mention. So that's important. And then you mentioned transesophageal echocardiogram as a test that we often do to try to assess what's going on with cardiac devices. There's a lot of discussion about some newer tests, one of which is a PET-CT in helping us to diagnose cardiovascular device infections. What do we know about the utility of PET-CT, and do you have any advice about when we should be asking for it?
Yes, really great question. So first, I want to back up just a bit and reemphasize that TEE really is the tried and true diagnostic test of first choice when we are evaluating these patients and trying to rule in or rule out device infection. However, if the TEE is uninformative, PET-CT can provide additional information. So PET-CT actually has high sensitivity for pocket infection, so greater than 90%. However, it has much lower sensitivity for lead infection, somewhere around 60%. So, and that's really kind of the crux of the issue, because a lot of times when someone has a pocket infection, that's pretty apparent clinically, and you don't need a PET-CT to tell you that. And what clinically, our big question is often, we don't see anything in the pocket, and our real question is that lead infected? And so we just have to understand that PET-CT isn't great for telling us if the lead is infected. It can sometimes give us an indication of infection at the insertion site into the myocardium, but again, not great sensitivity.
Clarification is really, really helpful as we think about how to order this test. Back to you.
Yeah, and so the other thing that PET-CT can help out with is providing information about extracardiac foci of infection. So pulmonary emboli or other systemic emboli that can suggest that this person has infective endocarditis. So it can provide some ancillary information. One does have to be careful about the potential for false positives, particularly in those who recently had a device implanted. And we think that that time where there can be false positives due to inflammation from the actual insertion of the device, we think that's about 3 months.
Really helpful information. So if we get to the place where we know or believe, I think we should use the right words, right? Believe the device is infected and needs to be removed. What's the best advice today about removal of device and then reimplantation of the device?
Yeah, this is really important. And this is what the consultees really rely on us to provide good advice for. And some of us are at large institutions where we even have patients who are transferred in specifically for the purpose of getting that device removed. And so anecdotally, we see that patients who have delayed device removal for whatever reason do poorly. And there are actually now a number of studies that show improvement in outcomes with early device removal. So in particular, there was a study of about 6,000 patients with a cardiac device infection. This was published in 2022. These patients were split into those who had their device removed within 7 days and those who had their device removed beyond 7 days. And in this study, those who had their device removed within 7 days had better survival. And there's another study that had similar results. Basically, they were looking at the 10-day timeline. So those who had their device removed within 10 days had better survival compared to those who had their device removed after 10 days. And so in clinical practice, I think that aiming for a week, within a week, makes the most sense.
And then probably even harder, what about when you can put it back?
Yes, another important question. So all our patients get a TEE. And in those who do not have evidence of infective endocarditis, once the device is removed and they've cleared their bacteremia, then they can get their new device replaced within 72 hours. Now, there's some debate over what to do about patients who have evidence of infective endocarditis. And there is one study out there that shows improved survival in patients who had a delay of 14 days prior to device reimplantation. So in my practice, I recommend in patients with infective endocarditis that device reimplantation be delayed by 2 weeks, more or less.
That's great. That's great. I know that those are hard conversations, especially when patients are tenuous. So thank you for that. Last thing on this topic, leadless devices. So leadless pacemakers and subcutaneous implantable defibrillators are touted as devices that are resistant to infection. Do these ever get infected?
Yeah, so great question. So the general belief is, gosh, they don't get infected, but we've all had the anecdotal experience of seeing that person who did have that leadless pacemaker device infected. So to back up a bit, there are several reasons that we believe that leadless pacemakers are less prone to infection. So first, there's not a subcutaneous pocket, which can be a huge source of infection. They have a much smaller surface area than the regular transvenous devices. They are located in the right ventricle, and it's believed that because there's more turbulence in the right ventricle compared to the right atrium, they are less likely to get infected. And finally, these devices get endothelialized, which helps protect them from infection. And so the rate of infection of transvenous, so the regular devices, is estimated to be 1% to 2%. And in one study, that the rate of infection of leadless pacemakers was estimated to be orders of magnitude less, like somewhere around 0.001%. But it's really hard to know for sure because I think we don't have great data. The micro pacemaker study, which was published in 2016, had over 700 patients, and there were no reported infectious complications at 6 months. However, it's important to note that in a later report, 2% of patients in that study had developed what they labeled a serious infectious event, which was defined as bacteremia or infective endocarditis. So in those patients, all of those patients had TEEs, and none of those TEEs showed evidence of infection. However, it's really hard to know, right? Just because you don't see a vegetation doesn't necessarily mean that it's not infected. So I think it's really hard. I think it's a gray area. We also know, based on anecdotal experience, that some people do get infections of their leadless pacemaker. And at this point, it's really on a case report basis. And actually, recently, Ahmad Murad and colleagues published a collection of 8 cases in the literature of leadless pacemaker infections. And in all of those cases, all but one, the leadless pacemaker was removed as part of management. And we know that's a really big deal to remove those devices.
So thank you for that. It seems like a great area for a future study too. Let's turn our attention now to different anatomy and talk about prosthetic joint infection. So in many institutions in 2025, joint replacement is the most common surgery. It's now being performed in the outpatient setting, which is just amazing for people like us or people like me, more senior to you, who remembers having patients in the hospital for 2 weeks for a joint replacement, right? The technology has advanced, but we still see really debilitating and sometimes, mortality associated infections with prosthetic joints. So, we get a lot of questions about this population, right? So starting at the beginning, we hear from primary care docs, from physicians, and even from patients. I've been asked this by patients. Should patients with prosthetic joints take antibiotic prophylaxis before dental procedures to prevent the joint from being infected?
This is a really important and common question. And it's important for folks to know that the guidelines for antibiotic prophylaxis changed significantly in 2015 with the recognition that the risk of bacteremia from oral microbes secondary to routine activities of daily living far exceeds that of any single dental procedure. It also recognizes that antibiotic prophylaxis does not necessarily prevent infective endocarditis, and there are published cases where the microbe that caused the infection was resistant to the antibiotic that was chosen for prophylaxis. It's important to note that transient bacteremias from an oral source occur regularly. And this was demonstrated by a clinical trial by Peter Lockhart in oral medicine, where subjects were told to brush their teeth as they do usually, and their blood was drawn at regular intervals up to 20 minutes. And the cumulative incidence of bacteremia in these patients was 23%. So we are transiently bacteremic a lot more than we like to believe that we are. And in the vast majority of cases, the transient bacteremia is cleared by the body's immune system and nothing bad happens. So just to make the point that there's lots of transient bacteremia just with normal activities of daily living, and that far exceeds any risk from a dental cleaning or dental procedure that happens maybe once a year, maybe once every couple of years. So the new guidelines recommend that antibiotic prophylaxis prior to dental procedures should be done in those who are really at the highest risk of bad outcome. And so who are those folks? Those are folks with a history of infective endocarditis, those with prosthetic heart valves, including those with rings and clips, persons with certain types of congenital heart disease, heart transplant patients, and those with a mechanical circulatory support device. And importantly for clinicians, the key intervention and what we should be counseling all patients with is maintaining good oral hygiene. And so while the main focus of antibiotic prophylaxis has been on the prevention of infective endocarditis, this also applies to patients with prosthetic joint. And previously, the guidelines were that dental prophylaxis was recommended for all patients within 2 years total joint arthroplasty, and in specific high-risk patients beyond 2 years. Currently, routine antibiotic prophylaxis is not recommended in our patients with joints. And there's no evidence to link either dental or endoscopic treatments with prosthetic joint infections.
That's great. Very, very helpful. And I know a lot of change management involved in implementing these guidelines, but very, very helpful. So let's turn about treatment. So these are dreaded infections, and very often we as infectious disease consultants are involved in advising closely and managing the treatment of these infections for long periods of time. And so what are the standards in 2025, and can you comment especially about the choice of parenteral versus oral therapy for prosthetic joint infection?
Yeah, so the treatment of prosthetic joint infections is one of the infections that we see a lot and seems like one of the most fairly cookbooked type of management strategies. But that having been said, there are several variations in the management of patients with prosthetic joint infection, and ranging from the part that we as infectious diseases doctors don't have that much control over, which is really the surgical management. So there is a variety of types of surgical debridements that folks can get, ranging from DARE, which stands for debridement, antibiotics, and implant retention. There's the one-stage arthroplasty, and then the two-stage arthroplasty exchange. In the U.S., the gold standard is that provides the highest likelihood of cure is the two-stage arthroplasty, where patients get debrided, the implant is removed, they get a cement spacer to try to preserve the joint space, then they get antibiotics, and then finally get reimplantation 2 to 6 weeks down the road. So our antibiotic regimen has to mirror the type of surgical management that the patient has gotten. And so I would say that having done my training in the US, the antibiotic regimens that we chose were always fairly standard and straightforward. So, for example, for staphylococcal prosthetic joint infection, the standard would be an IV anti-staphylococcal antibiotic like vancomycin for MRSA or a cefazolin or nafcillin for MSSA, plus rifampin for 6 weeks. And then if the person had a DARE or a one-stage arthroplasty, then they would have, after the initial sort of heavy hitter 6 weeks of IV therapy, would get stepped down to an oral tail for 3 to 6 months, depending on whether they had a hip or a knee joint infection. To me, it has always been fairly straightforward and not really questioned very much that folks would always get the initial 6 weeks of IV antibiotics, and then whatever happened afterwards was kind of dependent on what kind of surgical management they had. And there was plus or minus months of oral therapy to follow. However, there are differing practice patterns in other parts of the world, and also a few recent clinical trials that call into question doing it exactly this way that we've been doing it for a long time. So specifically, in answer to your question about the IV antibiotics and durations, there was recently a study called the OVIVA study, which is the title basically stands for Oral versus IV Antibiotics for Bone and Joint Infection. This study took place in several centers in the UK, so did not take place in the US. It included patients with different types of bone and joint infection, so just plain old osteomyelitis, and then also prosthetic joint infections. And it's important to know that these prosthetic joint infections were managed variably. So some patients had DAREs, some patients had one-stage exchange, and some patients had two-stage exchange. This is a fairly large study, so about 500 patients in each group. And these patients were randomized to oral versus IV therapy. What's important to know about the study and what makes it kind of tricky to interpret is that the actual antibiotic choice, so which antibiotic, and the doses of the antibiotics were the clinician's choice, which makes sense clinically, but it's hard to interpret if you're looking at it from a study standpoint. So what happened was there were two groups, the oral versus IV, and what they found was that there was no difference in the primary outcome, which was treatment failure within 1 year. This study makes us question the need for having a routine 6 weeks of IV therapy prior to switching to oral antibiotics. And there could be some real advantages to being able to switch over to oral from a patient perspective. Why aren't we all doing this now? So there are a few issues that make clinicians uncomfortable. In this study, there is a heterogeneous group of patients. So some patients had just plain old osteo, and then others had joint infections that were managed variably in terms of their surgical debridement. They had different antibiotic regimens, and it's hard to know exactly which patients look like your patients and which antibiotics they used for those patients. And specifically in those who had oral regimens, they presumably had really high doses of antibiotics that we don't usually prescribe at that doses. So how was that done? It's hard to know. And then the durations differed. So it was based on the clinician. And just at baseline, we treat these patients sometimes for 3 to 6 months, but was it 3 or was it 6 or was it longer? And we just don't know that. And then finally, there were some patients who were excluded from the study because they had a pathogen for which there was no good oral option for the patient. On the one hand, it makes us think, well, there are probably patients out there who really don't need to be sent out on that 6-week regimen, and we could switch them to an oral regimen. But I think we could use some more clarity as to which patients those are.
Yeah, thank you. Agree fully. And the only thing I would add that was very interesting in OVIVA and POET is that the adverse event rates were similar in the orally treated patients compared to the IV treated patients. And so one thing that is worth considering is if you do treat orally for a long period, which we often do as mop-up in these patients, continuing your OPAT, continuing safety labs, and keeping an eye on these folks, because antibiotics are not benign, especially when used for long periods of time.
Yes, and it would involve the restructuring of our infrastructure for taking care of these patients, and that we're so reliant a lot of times on home health to deliver those labs to us. And what happens when they don't have a line and they won't get home health? We need a whole different way of doing things, way to get the patient to the laboratories to get their tests done so that we can monitor.
Yeah, exactly. Well, that bridges us to the last topic I wanted to touch on quickly, which is mechanical circulatory support. So in this edition of the clinics, it highlighted the updated 2024 ISHLT definitions and guidance for durable and mechanical circulatory devices. How common are bloodstream infections in patients with these devices?
So in a study from the IMAX database, and that's the International Registry for Mechanically Assisted Circulatory Support, what they found was that 12% of patients developed a bloodstream infection within the first 2 months after implant. And 86% of those were non-device in origin. So that's a good number of patients, and these are patients who got it from some other source. And this is a big deal because unlike folks who have a routine CVC infection, central venous catheter, you can't just pull the catheter. These are folks who need to have their device until their clinical status improves or until they have a heart transplant. So bloodstream infections are a really big deal in this group.
Yeah, and another factor is that, in my experience anyway, treating especially ventricular assist device infections, they're not often symptomatic. So you have to have a very high index of suspicion to draw those blood cultures. The number of times I've been surprised by not just strep, but even, Staph lugdunensis or, other organisms, it's substantial. Any clear risk factors for who's at highest risk for these infections?
Yeah, so the risk factors include those with a history of reoperation, those with elevated BMI, poor nutritional status, older age, frailty prior to device implantation, diabetes, and hyperglycemia. The modifiable ones being hyperglycemia and nutritional status. But the others are ones that certainly make sense and have their mirror risks in other types of device infections. Importantly, it's important to remember that TPN is a risk factor for candidemia in these folks.
How about diagnosis? Are there any pitfalls clinicians should be watching out for?
Yeah, so there are some serious potential pitfalls, as you alluded to earlier. So bloodstream infection can be much more subtle in patients with a mechanical circulatory support device. So, for example, for patients who are on ECMO, and there's certainly quite a few on any consultation service who are on ECMO, fevers can be masked by the cooling of blood as it circulates through the extracorporeal circuit. Also, patients may not display leukocytosis because activated white cells can adhere to the oxygenator. So these are the two major things that we follow in patients as indicators of infection, and these can be really tricky in patients on devices. On the other hand, leukocytosis and inflammation can occur early after the initiation of ECMO, and so you can also get false positives in terms of monitoring the white blood cell count. Therefore, as you mentioned, Dr. Boucher, close monitoring and a high degree of suspicion are needed.
Yeah, thanks for that, Professor Chu. And we've seen things like worsening of heart failure, as a tip-off that something's wrong. I mean, these patients are so fragile, and sometimes, you can't tell whether it's the heart is worse, there's an infection, or both. And so collaborating with our colleagues on the heart failure service is super important to have those discussions about what they think is going on. Are the settings different? What's going on with the ECMO circuit? All really, really vital to the best care of these patients.
I agree. Having those bedside discussions are really important and helpful.
Yeah, and then I guess the last thing, do you have any pearls of wisdom when we treat patients, especially those on ECMO, in terms of the best way to optimize our antibiotics? Yeah, I was thinking more about sort of the need for really good pharmacy collaboration around the dosing, because things vary so much in this population, and especially with ECMO, and if they're on CVVHD or other kinds of hemofiltration, it gets very, very complicated to sort out the doses.
I agree. It can be so easy to fall into your routine and not realize that the patient is really on the wrong dose of antibiotic, and that can be really critical.
Yeah, good. Well, really complicated topics. You made it sound easy. Thank you so much, Professor Chu, for your leadership of a great edition. I hope folks will read about these infections and more, and I thank you for spending time with us today.
Thank you, Dr. Boucher. It was a pleasure.
Thanks so much for taking the time to discuss these important topics, Dr. Chu and Dr. Boucher. And thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on advances in the prevention and management of device-associated infections, visit us.elsevierhealth.com/expert. Infectious Disease Clinics is available for individual print subscription with an accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical and surgical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter at Clinics Reviews and at ID Clinics, and subscribe to the Clinics Review Articles podcast wherever you get your podcasts.